والحقيقه دكتور شريف يعني وفر شويه من الكلام اللي انا كنت هقوله فعلا، ان التكنيك والاستراتيجي اللي المفروض ان احنا نادوبت في الحالات اللي زي دي more or less يبقى ان احنا نحاول نمنتين most physiological position of the lens. طيب I'll be presenting two surgical videos. Two cases presented more or less very similar presentation, both with sensory strabismus, very deep amblyopia, very high lenticular astigmatism, and this was actually the anterior segment photography of both cases with lens coloboma, persistent fetal vasculature, thick elongated ciliary body processes, and a large infranasal ciliary body cyst for the girl, an upper nasal cyst for the boy. They were both documented by the UBM, and also there was another cyst also documented by the UBM, which was not clinically apparent. This is the surgical video of the first case, and here my main strategy at the beginning to try to maintain a central continuous anterior rhexis, which might aid later in the IOL optic capture. And here, unfortunately, you have to go near the colobomatous edge because your aim is to center the rhexis on the pupil rather than on the crystalline lens. As you can see here, the lens is relatively stable, unlike cases with subluxation and zonular dehiscence. You can even see the zonules elongated but intact. And then I proceeded to a posterior capsule rhexis, doing the incision and injecting viscodispersive to push the anterior hyaloid back. As anticipated, it stopped at this fibrotic part of the persistent fetal vasculature, and I had to cut it with the cystotome. Alternatively, also micro scissors could have worked, and then successfully completing the posterior rhexis. You can notice here the large persistent hyaloid artery from which two smaller vessels are emerging. Here you can see the opacity is at a level behind the posterior capsule at the anterior hyaloid, cutting it with the cutter along with a limited anterior vitrectomy. And now you have an intact anterior posterior rhexis, and I implanted the three-piece IOL in the ciliary sulcus, and actually unintentionally the optic went into the capsular bag. And here you can see the IOL maintained the central position. Even the haptics pushed the ciliary body processes with the whole bag nasally. And at the end of the surgery, just this microhyphema from the small vessels could be easily aspirated, but you should be also prepared with endothermy. Here I also captured the optic behind the posterior capsule to have a complete optic capture, and this was at the conclusion of surgery. And this is the post-operative pictures, dilated and undilated, with the exact intended target refraction of +1/2. This is the surgery of the other case, also with the same strategy. They were like just a couple of months apart, but again, in these cases, the main key or strategy is to maintain a central anterior capsular rhexis for the sake of the capture to guarantee the central position of the IOL later on. Notice the fluctuation of the cyst all through the procedure. You should just ignore it, and again, performing the posterior rhexis. Here, luckily, it did not stop at this fibrotic part, but it extended to the colobomatous edge of the lens. I had to complete it from the other side, cut it and remove it, but again, maintaining both rhexis continuous for the implantation. And again, the main aim was to do the capture, although the size of both rhexis was smaller than usual, but we have to do this because extending it to the temporal part will end with an eccentric opening. So this is the picture of the boy just a couple of weeks after the surgery, again also with resolution of the high lenticular irregular astigmatism. And this is actually reported before that whenever you have a lens coloboma, the ciliary body cyst may be an under-recognized cause of these cases. And thank you.